Hello everyone, I'm Sheldon Baker and welcome to Healthy Bytes. My guest today is Dr. Avishek Kumar. He is a board-certified medical oncologist. He focuses on modern evidence-based cancer treatment, second opinions, and infusion therapies. He also serves as a lieutenant colonel in the U.S. Air Force Reserve as a flight surgeon. He is deployed overseas and regularly flies on fighter aircraft in support of operational missions, bringing a high-performance, mission-driven mindset to medicine and leadership. Joining us from Edison, New Jersey is Dr. Kumar. Welcome to Healthy Bytes. And have you flown any overseas missions lately?
Not quite overseas missions, but I was recently on a Army helicopter from Fort Dix, and we made loops around the Statue of Liberty and flew down the Hudson River, so that was a lot of fun. It was a evacuation training mission, so it was a good time.
Very good, very good. Thank you. So let's get into this interview. Cancer treatment has changed dramatically in recent years. Why do you find oncologists moving away from a one-size-fits-all chemotherapy approach?
Well, for decades, cancer was treated in a geographical fashion. We treat a breast cancer a certain way, a lung cancer a certain way, colon cancer a certain way. To some extent, that's still true, but these days we're using a much more bespoke approach. So if we have a cancer, we not only look at the actual pathology from the tissue of the cancer, but we also look at the genetic underpinnings. And in doing so, we can look for weak spots in the armor of the cancer, and we can target our armamentarium of medications towards those weak spots.
Something that I've thought about a lot is why can two patients with the exact same type of cancer receive completely different treatment plans?
Well, if you have two patients with the exact same type of cancer, they may be biologically or genetically or molecularly very different. So these days we look at the genetic makeup of the cancer rather than just its location. And say you have a lung cancer patient and they happen to have an EGFR mutation. Well, patients like that, oftentimes they can do really well just by taking a pill every single day. And even if they're stage 4, they can live potentially for years. Whereas if you have another patient who doesn't have such a mutation and you treat them with conventional chemotherapy, they may still do okay, but the outcomes may be vastly different.
Many patients, I believe, still picture chemotherapy from 20, 30 years ago, but modern cancer treatment has evolved. And would you say the effects are not always as severe as many people fear?
That's true. People have this conception of chemotherapy being some sort of giant vat of green Drano that we infuse into patients, and really that's really evolved. This isn't the 60s or the 70s or heck even the 80s anymore. And even in the last 10 years, there's been leaps and bounds in terms of our innovations that we've used to treat cancer. And in effect, the cancer treatments have grown more efficacious, whether it's chemotherapy, immunotherapy, targeted therapy, or whatever else. And on top of that, our supportive medications have grown much, much better. And so we're able to control the side effects. We're able to potentially reduce the amount of nausea, reduce the amount of immunosuppression, and overall, for many of these patients, ensure a much better quality of life while being treated for cancer.
What would you say are some of the other biggest misconceptions patients still have about cancer treatment, and where might second opinions fit into the process?
Well, look, cancer is a very complicated and nuanced kind of a topic. And a lot of the misconceptions, they lie within the fact that people conceive that, well, if I'm being treated for cancer, the treatment's going to take over my whole life. I'm going to live in a hospital. I won't be able to see any friends or family. And I'm going to be so weak or so nauseous that I'll be unable to move. And this is largely untrue, particularly if you have a patient who was functional before the diagnosis of the cancer. I've got cancer patients who go to work every day. I've got cancer patients who attend family events. They fly off to see weddings in Hawaii or India or California. And oftentimes, a lot of these cancers are, in fact, we're able to put them in remission. So that's really changed. And in terms of second opinions, a second opinion should never be construed as an affront to your initial doctor. I send patients for second opinions at big university centers or Memorial Sloan Kettering or Hackensack or Robert Wood Johnson all the time, because that additional perspective from somebody who may have additional expertise or training or access to clinical trials can really shed light on terms of how to best go about treating a cancer. And that's where the second opinion can be invaluable.
But doctors aren't upset when a patient gets a second opinion, are they?
They shouldn't be. I mean, I'm never upset when somebody goes for a second opinion. In fact, I encourage it, because no single doctor has all the answers. And sometimes by having somebody who's got more experience or more training or has a particular clinical interest in something can help the patient. And our real goal is to help the patient. And so a second opinion can really help make that goal a reality.
Are you seeing less cancer or an increase in various cancers from your patients?
It's really variable. Now, these days, we're doing a lot more screening. So we're encouraging patients now, 45 and younger, if they don't have any risk factors, to go and get a colonoscopy. And this is detecting more cancers, so that's great, because if we catch a cancer early, we're able to treat it, and in some cases get rid of it altogether. So we are detecting more cancers, but there's also the environmental factors that come into play as well. People in 2026 in Western countries, in the United States, in general, we're seeing a lot more obesity. We're seeing people eating a lot more processed foods. We're seeing much more sedentary lifestyles where people may just be in front of a computer all day and not physically active. So all these different components, they have some bearing on different cancers. So obesity is a risk factor potentially. Sometimes more processed foods can be a risk factor. So it's kind of a mixed bag. We're detecting more, but there's also new risk factors that have become more broad in modern American society.
I think a lot of younger people, too, are also dealing with various cancers.
That's absolutely correct. We're seeing a definite increase, and I've talked about this on other media outlets as well, about the increase of colon cancer in younger populations. Just recently, there was a famous actor from my childhood named James Van Der Beek, and he unfortunately passed away from metastatic colon cancer. And he really wasn't that old. And now we are seeing a lot more patients who are in their 30s or 40s, or in some cases even younger, developing colon cancer at younger ages. So much so that the guidelines just a few years ago were shifted from the previous 50 years of age when it was recommended to get a colonoscopy, now down to 45.
Would you say that, especially in young people, if they're dealing or have dealt with colon cancer, has to do from, as you indicated, diet and eating, say, ultra-processed foods?
Multifactorial. All those things play a role. So we can't exactly put a percentage on what percentage was diet, what percentage was processed foods, what percentage was exposures to maybe chemicals in the environment, what percentage was obesity. But in general, all the healthy lifestyle choices that people can make, the things that we can directly control, a lot of our country, unfortunately, isn't doing. Every primary care doctor will tell you, diet and exercise and eat blueberries and strawberries. Don't eat fast food and processed foods. Now, fast food and processed food has become a lot more accessible, and it's relatively cheap, and it tastes good. And I love my occasional fast food or pizza or bagels or whatever else, but it shouldn't be the primary component of our diet.
Does some of it, too, just come down to dumb luck?
Oh, absolutely. Absolutely, it does. And not infrequently, I run into patients who have been smoking for 50 years and eating bacon and eggs deep fried every morning, and they live to 100. Now, this can happen. It doesn't mean that it's a good idea to have those habits, but certainly it can happen.
Last question, doctor. When someone is newly diagnosed with cancer, what is the single most important question they should be asking their doctor early on in the process?
Now, you should ask your doctor. It's usually a pattern of doctors. You might be initially seen by a primary care doctor and then referred to, say, a pulmonologist if it's a lung mass on the imaging, or gastroenterologist if it's suspected it's a colon cancer. But eventually, you'll end up with a medical oncologist. Medical oncologist is kind of like the quarterback of the whole team. And generally speaking, once you have a tissue sample, any patient should rightfully ask, has the molecular and genetic profile of the cancer been established? Because in doing so, we can really carve out a very bespoke way of treating the cancer, which would likely lead to a better outcome and also better tolerability. So these things go hand in hand.
Dr. Kumar, thank you for joining me on Healthy Bites, and keep flying high and safe.
Thank you, sir. It's a pleasure to be here.
And thanks to all of you for watching Healthy Bites.